Very good afternoon. Uh, at the outset, I would like to thank Abhishek for calling me here. And so we have discussed about four chamber views in which we have discussed left ventricular lesions and right ventricular lesions. Now we will go one step ahead, that is the great arteries. So introducing the topic, the anomalies of the outflow tracts are very important group of congenital heart disease. They are also known as conotruncal abnormalities. Most of them are critical and life-threatening. Most of them are amenable to complete correction with good outcomes if you diagnose prenatally. And they are often associated with genetic syndromes, most commonly 22q11 microdeletion, also known as Dijot syndrome. Now, as Mansi told, we should sequential segmental analysis should be done in the heart. So, after confirming the situs, we will see veno-atrial connections, atrioventricular connections, and after ventricles, we will see the ventriculo-arterial junction, that is the great arteries. So, we will discussing this segment. So, in conotruncal abnormalities, we have Tetralogy of Fallot spectrum, common arterial trunk, double outrate right ventricle, and transposition of great arteries, that is simple TGA and congenitally corrected transposition. So before going into the abnormalities, then let us refresh our normal anatomy. This is the normal LVOT view. Here we can see there is septo-aortic continuity. So this is the bold red line showing the interventricular septum, which is continued as anterior wall of the aorta. This is known as septo-aortic continuity, which forms an obtuse angle. And also posteriorly, if you see, there is mitral aortic continuity. So this is also important. The image on the right showed the 3D stick rendering, and this is the color Doppler image showing the left ventricular outflow tract. Coming to the right ventricular outflow tract, here this is classical short axis view. This is also known as circle and sausage view. Here we can see there is, this is the right atrium, tricuspid valve, the part of right ventricle. This is the infundibular region. Here will be the pulmonary valve. This is the main pulmonary artery which divides into two. Here we cannot see the left pulmonary artery. This is the right pulmonary artery, goes behind the aorta, and this is the ductus arteriosus. This is in the color Doppler image. Here we can see the pulmonary bifurcation. This is the infundibular region. This is the RVOT in the long axis view. Here we can see the RVOT goes from anterior wall to the up to the spine in a straight fashion. So this is also known as, this is some oblique view of three vessel trachea view, which we will discuss later. This is the TUI imaging showing, this is the multiplanar display from the stick. Here we can see both the LVOT and the RVOT together, and we can see normal crossover. So this is very important in conotruncal abnormalities. We have to look for the crossover of the both aorta and the pulmonary arteries. So here we can see this is the four chamber view. There is normal offset. Here this is the left ventricular outflow tract. That is the direction of the left ventricular outflow tract going to the right shoulder, and this is the right pulmonary outflow tract. So this is a crossover. Okay. So this is again in the color. So if you don't see any crossover, suspect DORV or TGA. So this is in the stick image. Here we can see this is the RVOT or the pulmonary artery, and below is the aorta, LVOT. This is normal crossover. So this is very normal. Now instead of going into theory, we will discuss cases, and then we'll have some few theoretical points. So what do we see here first? So what is the conspicuous finding here? There is left axis deviation. The four chamber view is absolutely normal. In most of the conotruncal abnormalities, you will find four chamber view normal. So in five chamber view or the LVOT view, we can see there is no septo-aortic continuity. Okay, so there is no angle formation here. So this is loss of septo-aortic continuity, and if you see, the aorta is sitting over the interventricular septum, that is known as overriding of the aorta. Okay, so this is the body and these are two legs which is sitting on the interventricular septum. This is overriding of aorta. Whenever we see overriding, look for the three vessel trachea view. So this is normal aortic arch, and if you see the pulmonary artery which is very narrow, whenever you see narrow pulmonary artery, look for the color, whether it is a antegrade flow or a retrograde flow. Here in this case there is a narrow pulmonary artery with the antegrade flow. So this is the video showing left axis deviation. Here we can see there is overriding of the aorta and there is a very narrow pulmonary artery here, and on the color Doppler we can see overriding and forward flow in the pulmonary artery. So we are dealing with, and also in three vessel trachea view we do not find, this is a normal control case which showing there is a V formation onto the left of the trachea. So this is a normal three vessel trachea view with the V on the left of the trachea, but here we can see instead of V we are seeing a narrow pulmonary artery with Y formation. Okay, so this is classical of Tetralogy of Fallot. So it is one of the most common form of cyanotic congenital heart disease. It is characterized by four main anatomic features. First is myelin VSD, second is overriding of aorta, third is RVOT obstruction. Most commonly it is infundibular obstruction, and sometimes it can be valvular also, which will lead to pulmonary stenosis. And fourth feature is right ventricular hypertrophy, which is not a prenatal feature, it is a postnatal feature. So what are the associated cardiac and extracardiac findings? So it can be associated with PFO or ASD in about 80% of the cases, right aortic arch in 25% of the cases, PLSVC in 11% of the cases, AVSD and anomalous pulmonary venous return. Extracardiac anomalies can be there. Chromosomal abnormalities are about in 30% of the cases. Dijot syndrome in about 10 to 15% of the cases, and other systemic anomalies are also common. So whenever we find TOF, we have to advise invasive testing to get a chromosomal workup done. So coming to case number 2, this is a very old case, so sorry for the images. Here also there is a left axis deviation, normal 4-chamber view. On the 5-chamber view we can see there is an overriding of aorta. Okay, so there is no septo-aortic continuity, but you can see the mitral and aortic continuity is there. So we are not dealing with, I will come to that later. So here on the color Doppler depicting the same. Now we have again narrow pulmonary artery. Okay, and also branch pulmonary arteries are also narrow. Now the next step should be the color. Here there is a reversal of flow in the ductus arteriosus or the pulmonary artery, and this is the video showing the left axis deviation, overriding of aorta and narrow pulmonary artery, or almost nothing is seen on the three vessel trachea view. On color Doppler there is forward flow in the aortic arch and there is a reversal of flow on the pulmonary artery. So we are dealing with pulmonary atresia with ventricular septal defect, also known as Tetralogy of Fallot with pulmonary atresia. So here in this imaging representation there is a very narrow pulmonary artery with that is due to pulmonary atresia. It can be short or it can be absent. Main pulmonary artery can be absent, or in sometimes we can have major aorta pulmonary collaterals, that is also known as MAPCAS. So PA-VSD is characterized by pulmonary valve atresia, hypoplastic or very narrow pulmonary artery. Always there is membranous VSD, overriding aorta. It accounts for 20% of all cases of TOF, and risk of microdeletion increases to up to 25%. If MAPCAS are present, the risk is about 50%. What are the associated findings? There is cardiac and extracardiac. Cardiac right aortic arch is in about 20 to 50% of the cases. ASD2 in 50% of the cases. There can be absence of ductus arteriosus as well in about 50% of the cases, and MAPCAS are in about 50 to 60% of the cases. Chromosomal abnormalities are common in about 40% of the cases. Here the deletion Dijot syndrome risk increases by 25%, and single gene disorders can be present in 4 to 5% of the cases. Coming to case 3. So what are your findings? Left axis deviation, there is VSD overriding. Now we have dilated pulmonary artery with dilated branch pulmonary arteries, and if you see, the pulmonary valve annulus is very narrow. Here, this is very narrow. So on color Doppler, if you put color, you will find there is a forward and regurgitation, because there is no pulmonary valve, only the infundibulum. So this is known as absent pulmonary valve syndrome, also known as TOF with absent pulmonary valve. It accounts for 3 to 6% of all cases of TOF. It is characterized by absent, dysplastic or rudimentary pulmonary valve. There is always a large malaligned VSD. There will be overriding of aorta, and there is always absence of ductus arteriosus. The main right and left pulmonary arteries are severely dilated. So this is in 3 vessel trachea view, it is a 1.5 second diagnosis. Okay, this is Potter. So what are the associated cardiac findings? Right aortic arch is about 20% of the cases. Absent ductus arteriosus in 88 to 90% of the cases. Extra cardiac findings are there is high association of chromosomal abnormalities, Digeorge syndrome in about 40% of the cases. Because of the dilated pulmonary artery, it will put the pressure on trachea and bronchus. That will lead to bronchomalacia, and that will also lead to, because of increased flow into the lungs, that will lead to poor lung development, and these are the life-threatening condition. So this is the differentiating features between TOF with stenosis, TOF with atresia, and TOF with absent pulmonary valve. What are the poor prognostic signs in TOF? So if you see a TOF, you always do the sequential scan. On the sequential scans, if you see the decelerated growth of pulmonary artery, or there is an accelerated growth of ascending aorta. So whenever we have PV to AV ratio is less than 0.6 or PV Z score, pulmonary valve Z score is less than -3. This is a poor prognostic sign. If there is a cessation of forward flow through the pulmonary valve, initially it was there, but now it has stopped. That is also poor prognostic sign. If there is a reversal of flow through the ductus arteriosus, if there is a TOF with pulmonary valve atresia or TOF with absent pulmonary valve, if there are associated chromosomal problems, associated extracardiac congenital malformation, if there is left ventricle, and if there is an abnormal venous connection. These are all poor prognostic signs in Tetralogy of Fallot. Now coming to case study 4. So here again we have normal 4-chamber view except from the left axis deviation. In the 5-chamber view we can see there is an overriding vessel. Whenever we see overriding vessel, we need to see the pulmonary artery. So this is an overriding vessel. This is on the color, we can see the overriding great artery. Here we can see there is an overriding vessel, but the pulmonary artery is arising from the main truncus. So we are dealing with common arterial trunk. So this is the color Doppler image. Here we can see this is the truncal valve and the pulmonary artery, which is small, arising from the main truncus. And on the 3-vessel trachea view, we don't see third pulmonary artery. This is the aorta, this is the trachea, but this is on the right side. So we are dealing with CAT with right aortic arch. So common arterial trunk, it's a single outflow, arises from the heart. It gives systemic coronary and pulmonary circulation. Large VSD is almost always present. So there are 3 types of CAT. Type 1, the main pulmonary artery arises from the truncus. Type 2, when 2 separate pulmonary branches arising from with very close distance. If they are far from each other, that is type 3. So the root of CAT is large and have a biventricular origin in most of the cases, but up to 1/3 of the cases it can arising directly from the right ventricle also. In very rare cases it can arise from the left ventricle, and the truncal valve is often dysplastic and thickened. The truncal valve is tricuspid in about 70% of the cases, quadricuspid in 22% of the cases. It can be bicuspid. It can have 1, 5 or more, but it is very rare. The associated anomalies cardiac are very common. Absent ductus arteriosus in 50% of the cases, right aortic arch 20 to 40% of the cases, as we have seen in our case, interrupted aortic arch, PLSVC, and retroaortic course of left brachiocephalic vein. Extracardiac structural malformation are also common, that is about 40% of the cases, and chromosomal are also very common. In about 4 to 5% cases, it can be associated with trisomy 21, 13, and 18. Microdeletion, Dijor syndrome in about 30 to 40% of the cases. Coming to next case. So here there is a large VSD we can see, and this is the pulmonary artery which is entirely arising from the right ventricle. So here we have a VSD and this is the left ventricle, but the pulmonary artery arising from the right ventricle. So this is the pulmonary valve, this is the right ventricle, this is the left ventricle. But it is atretic. Coming to another case. So we have a single vessel on 3 vessel trachea view. There is a large VSD there. The aorta is arising from the right ventricle. And there is a pulmonary artery also arising from the right ventricle. We can, how to differentiate it from the CAT? Because we see 2 different semilunar valves, aorta and pulmonary, side by side. And here the pulmonary artery is on the left side and there is a large subpulmonic VSD. So this is a still image. Here we can see there is a large VSD. This is the pulmonary artery and this is the aorta. Both are arising from the right ventricle. So this is a case of double outlet right ventricle. So this is the color Doppler image confirming our diagnosis. So what is DORV? Where both great vessels are arising from entirely from the right ventricle or predominantly whenever there is override. But if it is more than 50%, that is also considered as it is arising from the right ventricle. But the important factor here there is loss of aortomitral continuity. So associated with aortoseptal discontinuity, here we also have aortomitral discontinuity. VSD is almost always present. Pulmonary outflow is commonly obstructed. So depending on the VSD, we have different types of DORV. We can have subaortic VSD, we can have subpulmonic VSD, we have doubly committed VSD supplying both the ventricles, and we can have a remote VSD also. So there can be different relationship of great arteries in DORV. The most common type is side-by-side type of DORV. This is the most common. The aorta will be on the right of the pulmonary artery and subaortic VSD is common. Second is TGA type DORV. It is the second most type. VSD either it can be subpulmonic or subaortic. If there is a subpulmonic VSD, the subgroup is called toxic beam form of DORV, which we have seen in previous case. There can be TOF type of DORV as well. Here the feature, the differentiating feature from the simple TOF is we have more than 50% override. That is the TOF type of DORV. So whenever we have a VSD with overriding great artery, this algorithm has to be followed. Look for the pulmonary artery origin. So if it is arising from the right ventricle, either there is no visible pulmonary artery or it is arising from the single great artery. So if it is arising from the single great artery, it is CAT. If there is no visible pulmonary artery and reversal of flow in color Doppler, it is PA-VSD. Or if it is arising from the right ventricle, look for the size of the pulmonary artery. If it is normal, small or very small, if it is normal, it can be malaligned, simple VSD, perimembranous VSD. If there is a narrow pulmonary artery, it can be TOF. And if it is very small with reversal of flow in the pulmonary artery, it is PA-VSD. So we have completed TOF, CAT and DORV. So now coming to another subset of conotruncal abnormalities. This is normal 4-chamber view. Here on 3-vessel trachea view, we see only one artery, And here if you look closely, there is loss of crossover and the pulmonary artery which is bifurcating arising from the left ventricle. So the branching artery arising from the left ventricle and arching artery arising from the right ventricle, and there is a parallel outflow tracts. This is the color Doppler loop showing the arching vessel, that is the aorta arising from the right ventricle. So this is normal 4-chamber view, normal axis. Here there is no crossover and we have parallel outflow tracts. So here this is the parallel outflow tracts, and this is the branching, this is the aorta which gives rise to head and neck vessels, and on 3 vessel trachea view this is also known as I sign or boomerang sign. And this is the stick image showing the parallel outflow tracts. This is the pulmonary artery which is branching early, and this is the left ventricle, pulmonary artery, right ventricle, aorta. Coming to next case. So that was a simple DTGA. Again the similar case but with a twist. Here again the 4-chamber view is normal, but there is a VSD with subtle overriding. If you can see, so there is a VSD with subtle overriding. There is loss of septo-aortic continuity, and this is confirmed on color Doppler as well. So here we can see there is a VSD also. And again the pulmonary artery which is a branching arising from the left ventricle, and the aorta is arising from the anterior ventricle. So here this is the 4-chamber view which is normal. This is 3 vessel trachea view. Here it is showing I sign, and there is a VSD in the left LVOT view. So there is a subtle overriding and there is a branching artery. So this is a TGA with VSD. And in the stick we can have the we can see the parallel outflow tracts, and on the on-force view of the valves we can see the pulmonary valve and the aorta are lying side by side. So this is a subset called side by side TGA. So transposition of the great arteries, also known as DTGA, there is normal AV connection. So the left atria is connected to the left ventricle, right atrium is connected to the morphological right ventricle. So there will be AV concordance, while the aorta is arising from the right ventricle and the pulmonary artery arising from the left ventricle. This is known as VA, ventriculo-arterial discordance. And both because of they are arising from the different ventricles, there will be no crossover, there will be parallel course. So in 88% of the cases, aorta is anterior and to the right of pulmonary artery. So it accounts for 5 to 7% of all congenital malformation. Incidence is about 3 to 4 cases per 10,000 live births. There is slightly male preponderance. Isolated, it is known as simple DTGA. If it is associated with other cardiac malformation, that is known as complex DTGA. And VSD and pulmonary stenosis are common in about 30 to 40% of the cases. And associated extra cardiac malformation are very rare, and association with chromosomal problem is also very rare. Coming to case 9. So what is this a normal 4-chamber view? Anybody? Anything? Very good. So this is easily missed. So here we can see, always remember tricuspid valve is married to right ventricle. Okay. And in 3 vessel trachea view we have a single great artery. So here this is a still image. This is the pulmonary veins draining into the left atrium. Here the offset is reversed, and this is the right ventricle. This is the moderated bend. So the morphological right ventricle is lying on the left side, and this is the smooth left ventricle which is lying on the right side or the anteriorly. So we have ventricular inversion, and on the 3 vessel trachea view we can see there is a single. This is my last case. Single great artery, and if you see On the contrary to simple DTGA, there is close approximation between great artery and the SVC. Here there is some distance. So this is aorta arising from the morphological right ventricle, and from the anterior ventricle there is a branching vessel, that is pulmonary artery. Again, if you want to confirm, so we have three leaflets that is on the tricuspid valve, that is septal, anterior and posterior. So here there will be septal attachment of the septal leaflet which is lying on the left side. So this is morphological right ventricle. And on the short axis view of the mitral valve, this is typically fish mouth appearance because of anteromedial and posterolateral leaflets. So this is lying on the anterior side. So the anterior ventricle is left ventricle. So this is CCTGA, also known as LTGA. There is AV discordance and VA discordance. So there is double discordance. It is a very rare malformation. It accounts for 20% of all TGA. It accounts for less than 1% of all CHDs, and incidence is about 3 to 1 lakh. Associated anomalies, cardiac anomalies are common: VSD, pulmonary outflow obstruction, tricuspid valve abnormalities, dextrocardia, and rhythm disturbances. Why rhythm disturbances? Because the ventriculars are inverse, so there will be disruption in the normal electric signals. Extra cardiac anomalies are not specific. It can be associated with situs abnormalities, Digeot syndrome, and primary ciliary dyskinesia. So whenever we see corrected transposition, invasive procedure is recommended. The prognosis is generally uneventful. Immediate postnatal intervention is not required because it is congenitally corrected, but in the long run it has poor prognosis because the aorta is supplied by right ventricle, which is not designed for higher systemic resistance. So eventually it will fail. So what are the poor prognostic factors? There can be abstinence malformation of tricuspid valve, which is on the left side. There can be dysplasia of the tricuspid valve, or with varying degrees of tricuspid regurgitation. Systemic right ventricular failure, which can happen in third or fourth decade of life, and it can also associated with complete heart block because of the inversion of ventricle. So this is the last slide. So how to approach to the outflow tract abnormality? Look for whether we are dealing with two outflows or one. If there are two, if it is normally related or transposition. If they are normally related, look for the aorta mitral continuity. If it is present, it is TOF. If there is no continuity with the mitral valve, can be DORV TOF type. If there is a transposition of the great arteries, look for the aorta mitral or the great arterial continuity. If it is present, then it is simple TGA or TGA with VSD. If it is not there, it is DORV TGA type. And if there is one outflow tract, look for the direction of the flow. If there is the same and the main pulmonary artery is arising from the great artery, it is CAT, and if it is the reverse flow, it can be PA-VSD. Thank you very much.